Українські радіаційні онкологи, медичні фізики, слава Україні. Дуже дякуємо, що приєдналися до Research Methodology Course for Ukraine. Help Ukraine Group, Astra International Research and Development Committee are excited to present the sixth lecture of the course. And our topic today is evaluating randomized controlled trials, principles, and executions. Our speaker is Professor Becca Wong. She's a renowned radiation oncologist from Canada. We are very lucky to have her with us today. Dr. Wong is a professor of radiation oncology at the University of Toronto and Princess Margaret Cancer Center, where she currently serves as co-director of the Silver Family Theranostics Center, Director of Education, Radiotheranostics for Radiation Medicine Program, past Director of Clinical Trials Program, Radiation Medicine Vice Chair of the Education, Department of Radiation Oncology, University of Toronto. After graduating from Sheffield University and completing her radiation oncology residency at Queen's University, she obtained her master's in clinical epidemiology from McMaster University. The clinical and research efforts focus on improving outcomes for patients with gastroesophageal and metastatic cancers, including oligometastases. Dr. Wong's work emphasizes the optimal use of radiotherapy through clinical trials, outcomes research, evidence synthesis, and guideline development, and radiotheranostics. She has led multiple practice-changing initiatives, including multi-center clinical trials, evidence-based guidelines, as well as innovations, education, and training. She is a recipient of Canadian Nuclear Isotope Council Academic Leadership Award, Canadian Clinical Trial Group Joseph Pater Founders Award for Excellence in Clinical Trial Research, Fellow of American Society of Radiation Oncology. Dr. Wong has become a fellow this year, so congratulations. So that's very, we are very happy for you. She is a globally recognized leader in clinical trial design, knowledge translation, palliative radiotherapy, and global oncology. And we are very honored to have you with us today, Dr. Wong. Thank you so much for teaching us during your trip to Barcelona. So we are very eager to learn about randomized controlled trials. And the mic is yours. I'll stop sharing.
Thank you, Dr. Kovajuk. It's an amazing project that you have launched, and I'm very honored to be here. So I'm going to share my slides. Can you see my slides okay?
Yeah, excellent.
Okay, great. So randomized trials, principles, and execution. So throughout this course, you have been learning about different clinical trial designs. And today we're going to spend the next hour talking about randomized controlled trials. Obviously, writing the protocol and designing the experiment is the crux of the matter. But there are a lot of things that needs to be paid attention to beyond writing the protocol. Writing the protocol is like having a brilliant architecture drawing of building your house. As you try to implement your architectural drawing, all kinds of things can go wrong, and you need to adjust according to the circumstances. But as much as possible, you don't want to change the fundamental purpose of your plan, and knowing what is important, what are the key features, will help you protect the original intention of your treatment design. The statistical analysis, I'm thinking it's a kind of analogous to turning the power, turning the water on when you have your beautiful house. Whether you're collecting the data that would actually answer your question in a nice and strong methodological way, or is it full of holes and is going to cause flooding and destroy your house? It's all in the data and the statistical analyses. So we'll talk about the statistical design and some of the key features, and then we'll talk about some of the factors in terms of implementation of a randomized trial, setting yourself up for success, including study implementation, monitoring, statistical analysis plan, reporting. I'll touch on them in very general terms, but hopefully it will provide a good landscape for you to launch your study. So before we talk about randomized trials, you want to read about it, know about it, perhaps it's helpful to define it. So I will offer the definition that it is a type of study in which participants are randomly assigned to one or two or more interventions. The groups are treated and observed in an identical manner as per your protocol. They're followed up in the same way with the same tools. And they are analyzed for outcomes as defined in the protocol at the outset to determine the relative effectiveness of the interventions. It's regarded as the gold standard for evaluating the effectiveness of any intervention compared with another treatment, typically the standard of care. On the right, you see the hierarchy of evidence. You've seen that multiple times. At the bottom is case reports, case series, and then you move up when you are able to find some type of control, maybe historical, maybe it just happens that they are treated by different physicians using a different approach. And then you move up to cohort studies and then ultimately to randomized controlled trials. With moving up the hierarchy, basically you reduce the bias that may be inherent in the data so that you have increasing confidence and power of inference between the intervention that you have administered and the outcome that you have observed. You've controlled everything else, and there are just these two elements that are changing, and you can say it's because of how I did the intervention that the outcome is the way that I've observed it. That's the whole purpose of running a randomized trial. I put it slightly separately. On top of that, there's also knowledge synthesis type of methodology, systematic reviews, and meta-analyses. When you have several, more than one, randomized trial that ask a similar question using similar methodology, you can quantitatively pull them together, and that's what a meta-analysis is. When you have under good conditions where the trials are high quality and ask a similar question, by pulling them together through the meta-analysis methodology, you increase the power of drawing a conclusion. Therefore, it is more powerful. However, there are also situations where meta-analyses are subsequently proven wrong in larger randomized trials. So usually you have a bunch of smaller randomized trials. That's because that's what the global investigators are able to and have the resources to ask. We come and do a meta-analysis. Ideally, you do another large-scale randomized trial that is of equivalent power and be able to ultimately answer the question that you've set out to do. So that's a hierarchy of evidence, and randomized controlled trials play a critical role. So Natalia charged me with creating 5 questions. These are not really testing questions, but help me focus our message. So the first question is, what is the purpose of performing a randomized controlled trial? Natalia, do I read it out or let people read it themselves?
Yeah, you can read out in English, so it's translated at the same time, so I can see the translation.
Okay, perfect. So what is the purpose of performing a randomized controlled trial? A, to allow researchers to collect data from groups of patients who have received different treatments. B, to help patients decide which treatment to accept when there's more than one choice available. C, to allow patients to access treatments that otherwise would not be available. D, to reduce bias so the observed difference in outcomes can be attributed to the intervention patients are randomly assigned to. And E, to describe a research plan that can be used to get REB approval.
right? So we'll wait until approximately 80% answers because we're using it also to check attendance. Let's see what people are answering. We need a little bit more answers, please. Okay. We have 63%. Okay, so I am ending a poll and sharing results. So majority answered D, to reduce bias so the observed difference in outcomes can be attributed to the intervention patients are randomly assigned to.
Perfect. So that is the answer. Bias is the key question. We want to eliminate bias. The other factors are very often found in randomized controlled trials, but that is not really the purpose of doing such a trial. And certainly item C is not true because patients do not get to choose. In fact, the investigators do not get to choose. That's the whole purpose, is randomly assigned. So great.
Thank you.
Before we launch into looking at the characteristics of randomized trials, I want to take a look at the bird's eye view. What is the oncology community doing with this tool, randomized controlled trials? And this group of researchers have a strong interest in global oncology, performed this and published on looking at the characteristics of oncology randomized trials with a focus on the difference between low and middle income countries. They collected almost 700 randomized trials that was identified between a period of 2014 and 2017. Perhaps not surprisingly, the common cancers are commonly addressed through randomized trials: breast, lung, colorectal cancer. There's actually a large proportion of hematological and others as well. Perhaps a little bit disappointing, 87% of them are on systemic therapy, and only 6% of trials are in relation to radiotherapy, and only 2% relates to surgical interventions. The characteristics of the clinical trials are also of interest. Only about a third of the 30% of the trials uses overall survival as a primary outcome. The others are usually relapse-free survival, progression-free survival, symptom management constitute the majority. Obviously, overall survival is a hard endpoint and is of the greatest clinical significance. The relapse-free survival, progression-free survival is very much sensitive to how we follow these patients. So for example, progression-free survival, if you don't see them, if you only see them every 4 months, there's only the time that you can detect progression-free survival is at 4 months. You can't really detect it any earlier. And if you don't follow your protocol, and some patients are seen with larger frequency, then that would introduce a bias. So usually progression-free survival, relapse-free survival, those are considered interim endpoints. But it's generally attractive because it's a shorter follow-up time that you can get some results, whereas survival studies usually take many years to complete the accrual. Be that as it may, just we should be aware of those shortcomings of that type of outcomes. And as the data would show, that majority of randomized trials actually use the progression-free, relapse-free survival type of endpoints. I should also qualify that by saying that in some diseases, progression-free survival is linked and been shown to be correlated with overall survival. In those situations, it's it's quite acceptable to use progression-free survival as a primary endpoint, but it does require quite a lot of data to demonstrate that. The other contrast in this piece of work is that they noticed that industry-funded trials is much less common in studies done in the low and middle income country. The trial size tend to be smaller, about half the size as those done in high-income country. And the effect size tend to be larger. I think partly because the resource requirement and the number of patients that need to be involved, usually the studies performed in low and middle income country tend to demand a larger difference and hence requiring less size in this number of patients that need to be accrued, perhaps more clinically meaningful, but won't be able to detect small differences. The other finding is that randomized trials performed in LMIC tend to be published in journals with lower impact factors. The take-home message from the authors is that collectively we need to pay more attention to do trials in that proportionate to the population. So we need to do a lot more trials, especially in LMIC, perhaps with the global collaboration and more focus in other interventions such as radiation oncology, so we can define what's appropriate going forward. This is the second sort of bird's eye view paper I thought you might be interested in. Again, this group of global research, global scientists wrote this article about what are the important research questions for the radiation oncology community going forward, published just last year. And I pulled out a few things that perhaps is more relevant to our discussion here. They emphasize that we should think about redefining the indications for radiotherapy and the effective treatment regimen, perhaps focusing on best choice of dose fractionation, especially where resources are tight, and it's probably tight everywhere, and cover appropriate use of them. Explore the interplay between technology, staffing, and training. They particularly call out the role of AI-assisted contouring, planning. I think whether depending on the vendors we have, I think that's increasingly being used, and the next generation oncologists will grow up with these tools. So what are the impact of having them, both in terms of increasing efficiency as well as perhaps losing knowledge? That requires study. They also emphasize data-driven clinical trials for the future. Focusing on patient and tumor scenarios that are higher in frequency in certain countries and geographic distributions, and strategies to incorporate translational questions that provide depth of exploring the genomic and mechanistic questions. So we might not want to do genomic analysis on every patient on a randomized trial, but if we can set up the collaboration to collect the serum and imaging, it can teach us a lot more than patient outcomes alone. And finally, having emphasized that there's lots of data out there already that patients that are treated on clinical trials or in institutions that have a clinical trials program have better outcomes. That's an observation effect, like people are being, are monitored through the clinical trial process, and the quality goes up. So an important factor to motivate us to do clinical trials together. So when would you consider launching a randomized controlled trial? It's not for the lighthearted and probably isn't the first trial design that you want to choose. I think fundamentally you want to do a randomized trial only if you have data that suggests the intervention that you're interested in potentially provides better outcome than existing treatments. So if you have a core radiation methodology to give single fraction, spatially fractionated radiotherapy, it won't be appropriate to do a randomized trial on them tomorrow unless you have accumulated sufficient supportive data to mount a randomized trial. The other way of looking at it is that if you are on the panel to grant money to the investigators, would you approve the funding to run this trial? And I think resources are tight, so making sure that we're using resources appropriately, I think is one of the first questions I must ask myself. Is this a question for a randomized trial setting? You need to establish a causal relationship between the intervention and the outcome. If it doesn't matter, then and you're doing it anyways, then maybe not that important. Typically, it's evaluating a newer treatment that is emerging, and you need to know how it compares with no treatment or existing treatments, and how to prioritize it in the workflow in your clinical practice. Or it can be an older treatment that we've done forever and ever. But there's emerging evidence, and when you look back at the data, our residents are really good at doing this. Go look at the literature. Why are we doing this year in and year out? And you realize that it's just passed on from teacher to teacher, and actually the evidence is very, very limited. And that is a situation maybe you want to run a randomized trial and prove it once and for all whether it should be continued, especially when there's potential harm, including ineffectiveness. I think the classical example there is the use of bone marrow transplant for breast cancer patients. That was very popular at one point, but was proven to be ineffective and harmful. The other that in working with colleagues in developing countries, you might want to do a randomized trial, even though there are existing trials out there, because your population is different. Maybe for genomic characteristics, the intervention that you want to use or can deliver is different. Under those circumstances, it's good to do a randomized trial, building on the existing literature to demonstrate whether it works and how it works in your setting. So, question number 2. Which of these factors are not important prerequisites for a randomized trial to be successful? Option A, the type of patients you're interested in recruiting into the study is available. B, you have access to the equipment technology required to deliver the intervention. C, physicians are sufficiently uncertain about the benefit of the treatment and are comfortable to offer patients to participate in a randomized trial. D, the treatment arms need to be reasonably comparable for patients to be willing to be randomized to. And E, the treatment in the study need to be novel.
Waiting for more answers, or around 54%. Waiting for a little bit more answers, please. Okay, so 86% answered. Thank you. I am ending the poll, sharing the results. So if the answer is split between C and E, do you mind commenting?
Okay, so the question is not an important prerequisite. So the physicians need to be sufficiently uncertain and be willing to put the patients on the study. Otherwise, your study will not be successful. So a typical, I spend a lot of time running clinical trials with the Canadian Clinical Trials Group, and a couple of them are around surgery. Should surgery be done or not, say in esophageal cancer? And no matter how much data I show some of the surgeons, they say, oh no, radiation, you're going to cause side effects, and all the tissue is going to fall apart. I can't randomize a patient in these studies. And many centers would not open the study for that very reason, even though I show them multiple trials. And another the surgeon that is very globally recognized also attests to the fact that, yes, these are reliable data. Sometimes the physician's biases make it difficult. In fact, that's true for patients as well. They may not actually buy your data, and if they have the preconceived idea, your study will not be successful. So that's why E is my answer of choice.
Correct answer. Thank you.
So randomized trials, and if you're considering one, most likely you would do a superiority randomized controlled trial, such as this one, exposing somebody with an infection in ICU, and you put them on antibiotics, or a new antibiotic or an old one, to see what one is more effective. But randomized controlled trials are not confined to interventions, cancer treatment interventions. It could be preventive. It could be a quality improvement. It could be a teaching intervention. So, for example, in this one, patients are randomized to being reminded, physician groups reminded to offer them a flu shot versus not, and to test whether they're subsequently vaccinated or not. So for those, especially for those of you who are educators, it's pretty cool to do a randomized trial as an education intervention as well. So be creative. So the basic structure of a randomized controlled trial, I will take the next few slides to run through it. It starts with a well-structured question and hypotheses. I think you've seen the PICO thing multiple times and ad nauseum. So that's just to remind you, it starts with PICO, population, intervention, comparator, outcome, and perhaps time frame. This is what I mean, you can look at very detailed manuals to think about randomized controlled trial design, but this is what I think about when I'm sketching out what I'm going to do with my trial. Inclusion, exclusion criteria, whether I need to stratify or not, how I'm going to randomize, the characteristics of the study intervention and the control arm, primary outcome and secondary outcomes, and tertiary outcomes, and then sample size and analysis plan. So since it's a randomized controlled trial, let's start with randomization. So the randomization is the core thing that is being done to create equivalent groups where the only difference, ideally, is the intervention that we're going to administer to them. We already mentioned that superiority trial is probably most commonly considered, but there is increasing study design with increasing sophistication. You've read non-inferiority, equivalence trials. There's also phase 2 randomized trials. The idea is that there are two intervention. You might want to pick the winner, or 2 or 3. You might want to see which one is better, suggested to be better, because you don't have enough money, or the community, not just you or me, the community don't have enough resources to develop 3 different ones and then compare them with randomized trial. You want to take the most promising one or the least toxic one, and you do a phase 2 randomized trial. The idea is not to compare whether one is better than the other. You want to create 2 groups that are treated in a similar fashion, just like standard randomized trials. But you try and look at which one looks more promising, and then you take that one to a phase 3 trial. So phase 2 randomized trials can be used that way, and usually it requires a smaller number of patients and can use intermediate outcomes more readily. The key thing to remember is that it's not meant to be a comparative trial. And so the difference there is the statistics and sample size estimation. There are cluster randomization where whole institutions are being randomized. There are platform trials with umbrella and basket trials. There are adaptive designs. They become increasingly complex, and we won't be talking about them too much today. But just be aware that they are out there and can be put into use as our knowledge and experience grows. So randomization is a process of assigning study participant to experimental or control groups at random. So each participant has an equal chance of being assigned to a given group. The purpose, again, to emphasize, is to eliminate selection bias and balance the known and unknown confounding factors that may affect outcomes. I think the known is the things that you put in a characteristics of patient table. The sex may be different, the age may be, you already know those things probably make a difference, and you are careful to look at them to make sure they're balanced between the two groups. So the randomization process is supposed to allow you to end up with balancing of these known factors. But perhaps more importantly is what is unknown. So that it may be that the color of the hair makes a difference, but we didn't know that, we don't have substance. But by having that randomization process, it's more likely that those unknown factors are being controlled, so that you're more likely to be free of bias and be able to draw the conclusions that you're interested in drawing. Nowadays, I don't think anybody would do a randomization other than using a computer program. In the past, we used envelopes and random numbers. Those have been shown to be easy for physician. You hold up the envelope and you can see what the next one is. You know what the last patient got randomized to, so you can kind of guess what the next one is going to be. So as a physician advocating for your next patient, we all try to do that, and the computer program tries to protect us from that. In large trials, simple randomization, the computer generate A or B, is probably enough. But in smaller trials, you probably need to have more precautions. So block randomization or stratification, as well as looking at the factors themselves to make sure it is balanced as best as you can tell. So a word about stratification. I've already said, if you know certain factors, age, sex, hospitals, the size of the hospital, those may make a difference. So you don't want 20 stratification factor, but you want the most important ones, maybe 4 or 5 of them that you can stratify, so that the randomization process will be within these stratification stratas. And then at the end, after the randomization, you should have about equivalent numbers under each stratification factor for the factor that you are interested in. So that's one way of using stratification so that you are balanced and ensure the randomization process does its trick. The other reason why you might do stratification is that I'm really interested in knowing if I think that there is a difference in the effect size between men and women. Human beings should respond in the same way, but maybe men and women will respond differently. So you want to be able to say something about the effect size for the men subgroup and the women subgroup. In that type of setting, you will be stratifying by sex, but you will also need to adjust the sample size so that you have enough numbers in each of the subgroups to be able to comment on the outcome. If that is the purpose, very often it would significantly increase your sample want to conclude whether the treatment intervention works in one and works in the other, you pretty much have to double the sample size. That's just a back of an envelope. Your statistician will talk about that more. So again, you don't want to stratify for that purpose too many factors. Probably the most important one if you have to do it, because it will increase your sample size. So the next thing to talk about is inclusion and exclusion criteria. That seems quite obvious. You want to define the group that you want to infer the results to. So if you're doing a study on patients with rectal cancer and whether they should have radiotherapy or not, so you gather patients with T3 tumors, no metastatic disease, good enough to go through treatment, all those things that would define the group that you're interested in. After that, you probably want to include factors that would exclude comorbidities that would make it unsafe for you to administer your intervention. So if the patient have inflammatory bowel disease and they are likely to have a different toxicity profile, you might want to exclude them. And similarly, in other factors that you might be thinking of. You have to be careful, though. The more you exclude, the narrower your group is, and then you might have a very homogeneous group of patients. When you have the results, it will be, you can't apply the information to those that you have excluded. So the generalizability could be limited, but certainly you don't want your group of patients to be unable to complete the treatment that as best as you can tell and cannot give you your primary endpoint. I highlight the importance of getting the primary endpoint. Your whole study will be a waste if your patient that entered in your study do not give you your primary endpoint. So that's something to think about. If the purpose of your study is to change symptom profile, reduce pain, reduce nerve root compression, then you need to define how to measure those symptoms. Having them is probably not enough. Say in the case of pain, having pain, whether it's a grade 1 pain or a grade 9 pain, it will be different. It may be different and of significance, so we need to define that. The clinical setting for both the patients and the treatment, whether it's in a large academic center, community center, inpatient, outpatient, all of those, if it is important, need to be defined. And you want to define a group of patients that you expect to share a similar effect size. So I talked about male and female receiving radiotherapy. If it is a hormone treatment, then maybe women will respond very differently than men, and you might only do a females only study. So you have to have some basic understanding of an estimation as to whether they share similar outcomes to address them in the study, or you stratify them and make sure you have enough patients to address the subgroups that you're interested in. After you have defined your patient population, describing the intervention is the next critical thing, and the control group. Again, that may seem very obvious if you're giving radiotherapy, or how much dose, how to plan. So all of those things that you would prescribe for your regular patient, you need to lay it out what that is. If it is a radiotherapy regimen, you need to define the dose, the prescription, and not just radiotherapy. Obviously, that's to a radiation oncologist, that's very obvious. But say you're designing a surgical study, then you also need all the surgical details in as much as it can be standardized. So Beyond defining it, modification rules. So what would happen if the patient need to stop the treatment for 1 day? The patient need to stop the treatment for 2 weeks. What happens under those circumstances? So rules need to be written. The medical oncologists are very used to writing out with a hemoglobin is this, if the white count is this. So for radiation is the same, for surgery is the same. What is allowed, what isn't allowed, so that when you publish your study, people reading your trial knows what had happened to those patients and what type of what does the intervention actually look like. Strategies to maximize compliance. So if it is related to taking a pain relief study, whether they're taking the medications, how do you, which medications you allow? Are you allowing hydromorphone or morphine or oxycodone? You might allow all of them, in which case you might need a scale to be able to convert them, or you only allow one so that it's all standardized. Patients might not tell you the absolute truth. They might forget. So having a manual, having a pill count, all of those are strategies that are required to make sure you know what you think you have delivered has been delivered. Acceptable concomitant care, medications is an obvious one. So for bone metastases, you're giving radiotherapy for pain relief. The pain medication itself is a concomitant care. You can't preclude people from getting pain medication, but having rules as to how it need to be managed. So for example, a lot of these pain studies in radiotherapy would say you need to stabilize the patient's medication before you can go into the randomization process. So as best as you can, standardize it so that it's the same between the treatment arms. And then you have to design the equivalent for the control group. If you're doing a placebo, is the placebo easy for them to tell? Can it be produced and distributed, etc. So it has to be clearly laid out so that your staff that is implementing it for you knows what to do, and when you come to write the report, your readers know what you have done. So on to outcome designs. I think I've said it already. The question has to align with the primary outcome, which has to align with the statistics design. So if you're asking a question about pain relief, probability of pain relief following radiotherapy for bone metastases, say, then your primary outcome needs to be probability of pain relief at 1 month or 3 months, whatever you think it's most important. And the statistical design, sample size consideration, need to be directly related to the primary outcome that you have defined. Everything has to line up. And it's surprising how often when I work with students, they do not. By the time you've written the first hypothesis to getting to the statistical design has been several weeks, and they don't always line up. And making sure they line up is critical for any study, but particularly for a randomized trial. You can measure more than one thing, everything that you're interested in, provided that it is important and you're not wasting your resources to collect bits of data. Put it in the secondary outcome. Very often I'll also have a tertiary outcome, which is my translational. I collect blood sample to do this, that's very exploratory. But very often the primary outcome I have described, and then secondary outcome, your acute toxicity, late toxicity, and overall survival in a pain study, probably not very important, but you want to collect those as well. So all of those things go into secondary outcomes. Generally, the primary outcome is one thing. Even for pain relief, there are different ways that you can define, and it matters to your conclusion, and it matters to statistical analysis. So pain relief could be probability of patients who have pain relief at 1 month or at 6 months. So probability of pain relief. Or you could have the median duration of pain relief. The control group is 4 months, and I want it to be 6 months. The statistics is completely different. And what is more important to you, and you have enough patients to run the trial, drives how you will make those decisions. The other thing about the primary endpoint is that I mentioned if you put a patient into the study and you do not get the primary endpoint, the patient died before the primary endpoint, the patient lost to follow-up, they got sick and didn't want to come back to see you, your study is messed up if you don't have the primary endpoint. So the more attrition from your study, the weaker your study, and no amount of statistics can salvage that. So just to emphasize that point, in my early career, I start my career in palliative radiotherapy, thinking this is the coolest space that I could, lots of questions I could answer. I want symptom relief at 6 months, and everybody died by a lot of patients died by 4 months. And I realized that in palliative care, attrition of 20–30% is very common. So you don't want really to build a randomized trial knowing that you have a 30% attrition rate. So I actually compromise, instead of setting 6-month follow-up, whilst that might be the most important thing you really want to know, I set the primary outcome to be at 3 months. I know the majority of patients, I will have the data. You can still report on the 6 months, but you know that you have the answer that you'll be looking for, or most likely. So all of these things are relevant in thinking about a design. Another word about primary outcome, I said there should be one thing. Sometimes you could use two, and that becomes more complex, and there's a term for it, composite outcomes. I will refer you to your biostatistician, and I think that's an advanced level of study design. I think I've said enough, but primary endpoint is the most important thing to do it right. So the next feature is sample size and statistical consideration. You're sick of me saying that you have to align the question with the primary outcome with the statistics. So I'd say that again. And then statistical consideration is sample size and the statistical plan. So you based on what you're looking to find, the difference that you're looking for, the number of patients you might have, then you can estimate the number of patients that you require. That's what you need to go and get money to run this trial. In addition, the anticipated loss to follow-up, you can tolerate about 10–15%, but you don't really want much more than that. Required duration of follow-up, anticipated duration of the study. Statistical analysis plan, enunciating what are the potential confounders, how to minimize them, defining the endpoints of interest to measure. I might have another bullet somewhere else, but I'll say it now. If you are measuring an intervention and the outcome subsequently after the intervention, very often defining when is point zero, time zero is really important. Most clinically, you would think that, well, the time to my outcome would be after I finish my treatment. But from a statistical point of view, the only time that the two groups are identical is at the time of randomization, or at a pinch, the time the treatment starts. If you wait until the treatment completes, Sometimes, say one patient is having a 3-week course of radiotherapy and they're having a 1-day course of radiotherapy. The time you start the clock is different. It's worse still if you have a surgical patient and a radiotherapy patient, and the surgeon might have to wait for a few weeks to get started, or the radiotherapy may have to wait for a few weeks. There are all kinds of things that can go into the timeline that introduces bias. So usually the point 0 should be at the time of randomization or at the time of first treatment if you know that there's not much waiting time in between. It has to be consistent and typically not at the end of completing your intervention. So question number 3, which of the following factors are not required in a randomized trial protocol? So answer A, inclusion-exclusion criteria for eligible patients. Definition of the intervention with details on what are acceptable and unacceptable. There need to be alignment between 3 things in the protocol: the research question, the primary endpoint, and the rationale for the sample size justification. Agreement by the investigators on how many patients they are going to enroll into the study. Description of how the patients are to be followed, frequency, tests required, time window for acceptability.
And just a reminder that it's a negative question. Which of the following factors are not required? Okay, so we have some answers, a little bit more, please. Okay, I am ending the poll and sharing the results. So majority answered D, agreement by investigators on how many patients they're going to enroll in the study.
Correct, yes. These questions are actually very difficult to write. I want these answers, but sort of writing a wrong one is a little difficult.
Yes.
Yeah. Anyway, so you're correct. We have to project how many patients that we are likely to be enrolled, but it's usually not accurate, so it's not an agreement. So with sample size estimation, you'll be familiar with these terms, but just to state it, there's type 1 error, so conventionally set at 0.05. And in English, we will accept 1 in 20, so 5 out of 100. Chance that we will claim there is a difference between the groups when in truth there is not. Type 2 error will be usually set at 0.2, 0.1. We will accept a 1 in 5 chance that we will claim there is no difference between the groups when in truth there is. And the power of the study is 1 minus type 2 error. So type 1 is alpha, type 2 is beta. If you like pictures, this is what it looks like. The bell curve distribution of the patient's outcomes. The alpha error is 0.05, represented here. And the beta error, it represented in red.
And it's two-sided, right, Dr.
Yes, yeah. And the power is just a pictorial to indicate that is due to that is defined by a number of things, and that's what you need to bring to the biostatistician: the type 1, type 2 errors, the difference that you're looking for, the variance in the data, so how wide that bell curve might be. You can typically look in the data in published literature to have a rough estimate, and the number of patients that you might be able to have. It will govern the power of your study. So moving along, I want to talk a word about intention to treat analyses. That term may be already familiar to you. And what it means is that after randomization, all the patients that are randomized to each of the arms are included in the denominator for reporting of the primary outcome. That will be referred to as intention to treat analyses, as opposed to per protocol analyses. So if you have a study that is a radiotherapy study, and the patient only got 1 out of 5 weeks of radiotherapy, so it didn't get the intended intervention, a per protocol analysis will exclude that patient from the denominator and only report on patients who received the treatment as per protocol. So let's see question 4. You designed a study that involved randomizing patients with osteoporotic fracture to receive prophylactic vertebroplasty or watchful waiting. You're probably familiar with this procedure. They have a fracture, you put a needle into the vertebrae, inject some medical cement, and it sort of strengthens the bone. And here is talking about after an early fracture to receive this procedure to prevent a subsequent fracture. And the primary outcome is whether they develop a second fracture after the index one that brought them into the study. Now, 20 patients develop a fracture while they're waiting for the vertebroplasty in arm A, the top arm, arm A. So 20 patients developed a fracture in that gray period and did not proceed to prophylactic because they already fractured again, so they didn't have a prophylactic vertebroplasty. There's 100 patients in each arm. So what denominator will you use to calculate the primary outcome? Percentage developing new fracture post-vertebroplasty as designed in this study. So answer A is 100 for arm A and 100 for arm B. So everybody randomized to A and everybody randomized to B. Or 100 minus the 20 that had the fracture before they have a chance of getting the vertebroplasty because they were not eligible for the vertebroplasty. So 80 for arm B, and then 100 for arm B. C is you perform both analysis and report on both of them. And D is you declare that the study is not successful and close the study.
Okay, so waiting for a little bit more answers. Currently, we have 50%, 54% participating. Okay, I'm ending the poll, sharing results. So majority said A.
Wonderful. So by definition, that is intention to treat. And if you actually look at this example, this hypothetical example, actually it didn't work because there's the same number of patients that have fractures in both arms. But if you actually use the per protocol analysis, it will show that 20 out of 80 is more effective. So it just highlights that balance. Having said that, I think a lot of times clinicians would like to see both. Methodologically, we should report on the intention to treat. It doesn't hurt to provide the per protocol analysis, but it'll be wrong to report on the per protocol analysis. I think most of you got the message, but I would pick C, but I think A is a good answer as well. Reporting on treatment effect. The effects as relative effect between the two things can be relative risk, absolute risk, odds ratio, hazard ratios. Again, I refer you to the biostatistician. I already highlighted that even for the same description of outcome, you could report percentages, you can report mean, you can report median, you can have different time frame. You could use a Kaplan-Meier type of analysis to look at time to event. There are different ways that you could analyze it. Some are more intuitive for the physicians, some require more patience. So those are decisions that you would need to make together with the biostatistician. Other features of a randomized protocol design, interim analyses, safety, stopping rules, and quality assurance. If you think that you are running a very large study and you don't want to spend 5 years accruing and realize after 5 years that this study never had a chance to be positive on. So interim analysis allow you to look at whether it's good to complete the entire study. It will affect your sample size a bit, but for a very large study, it's very often important to have. Sometimes people build an interim analysis to look at toxicity to make sure it's safe. Stopping rules have the same idea. So data safety and monitoring board, most studies, randomized trials, if you're running one, would need one of those. Most institutions will have physicians that volunteered at the time to oversee the data safety for the institution. And quality assurance, I think that's, and not quality, I'm not referring to quality assurance of the intervention. I'm referring to quality assurance of your data. So it probably doesn't take a lot of imagination that I might forget to dictate on something, I might forget to measure something, and unless you're on top of it, it's very bad to, at the end of your study, figure out there's lots of missing data. So a quality assurance plan right from the beginning and have somebody in charge of that to make sure the quality is good is critical. Collecting the data, in most protocols, you have a schedule of events, and I look at this the most when I run a clinical trial. So it's very important to get this right. So it basically lay out when would things happen. An important lesson that I learned the hard way is make sure you have a window. You might say you want to do it at 1 week, 1 month, 3 months. But if you don't put a window there, your auditor will say it's not at 1 month. It's 32 days. You violated the protocol. So give yourself a window that is reasonable. Same with, make sure that these are clear and what is day one, so that everybody is counting the same way. Patient-reported outcomes is really, especially in phase 3 trials, quality of life and symptoms are frequently important, if not primary endpoint value add. The key things to remember is to, as best as you can, pick a validated questionnaire. Don't pick something that has so many pages or multiple quality of life that your patient will give up on completing the form. You want to do it in such a way that will give you what you want, but your patient and your study coordinator is going to be mad at you. So there's lots of guidance as to how to do this well. Refer you to those. It's just pictures, just to remind me to pictorially share with you like a superiority trial. That 0 here represent no difference in the trial, and the little boxes represent the point estimate, and the stem on either side represent the confidence interval. So when the confidence interval and the point estimate does not include the no difference, then it typically represents statistical significantly different. And when it's on the other side beyond the delta that you set for yourself in an inferior trial, then you can call it an inferior trial. And then in between, there's non-inferiority and equivalence. Again, this is too much to go through in this short presentation, but just be aware that they are these study designs. Disadvantages of a randomized controlled trial is a highly controlled experiment. And I mentioned earlier, inclusion-exclusion criteria may lead to a very homogeneous group, but if your patient population end up to be very different than the patient group that you want to apply it to, then it loses its external validity. It generally is expensive. At our center, a not very heavy-duty study would easily cost $5,000 per patient. And when you put in some drugs and other imaging things, it's like $10,000 a patient. So you really have to want to answer this question to mount a randomized trial. Feasibility, you need to make sure, we talked about equipoise earlier, patient willingness earlier, and be aware of overestimation of the patient and the physician's willingness to participate. It's a complex undertaking, and there's lots of methodological papers written about it. I provide this reference by Sabor. It's a short paper that I think lists many of the key elements. So if you want a quick read, that's a nice one. But if you want to be really detailed and set yourself for multi-center randomized trials, the SPIRIT guidelines detailed everything that you need to write in your paper, which therefore you need to put in your protocol. So that's a good reference to go with. So a few more minutes, conducting a clinical trial beyond the protocol. So money we talked about in my practice environment, very often I will have an exciting trial that I want to do, but it doesn't come with sufficient funding, and the institution will say, no, you can't run this trial. So funding is important, like everything else. I think that's when designing it in such a way that it's cost effective is important. So trial documents, beyond writing the protocol, there are other things that need to be written. The protocol need to be registered. If you have a trials group, they will usually register it for you, clinicaltrial.gov, or maybe in your region you have your own. So it needs to be publicly posted so that other people can reference it. Other people can potentially get your protocol and make sure you're not changing things as you go along, or have a good reason to do so. Consent form need to be written at a grade 6 language. Then there's typically operation manual, pharmacy manual, imaging manual, all of those to make sure that the processes that you are incorporated in your trial are done in the same way, especially if it is more than one center. You'll be surprised how doing a CT scan, one center to another is not exactly the same. So unless you specify it, you'll get whatever, which isn't very good. Data monitoring plan, we talked about getting somebody to look at the data. I get monitored. The first patient is randomized. Even before they get to follow-up, I get audited. So that's maybe a bit of an overkill, but make sure that there's a monitoring plan. And then data analysis plan we talked about. So it's way too much for a well-meaning investigator to do all of this. And it's important to have a clinical trial team behind you. And the bigger your organization, the more support you're likely to have, but hopefully at least a clinical trial list that work with you, even if it is a small scale randomized trial, single institution. So in my center, just to share our practice, and I'm sure other big centers will have different workflows. We have a regulatory affairs specialist. So when I have a trial coming in, I don't necessarily have written the protocol, maybe as a drug company or a collaborative group. The regulatory affairs specialist will make sure the consent form is there, the contracts are done, and help with getting that done. That needs to be sent to the Research Ethics Board, funding, starting an account. We have this thing called capture, and in any trial would touch other departments beyond your own. Like you can talk your department head and say, I want to do X, Y, and Z, but your patient probably need blood tests or patient need a CT scan. So all of those other departments need to be aware of your study, familiar with your protocol, and do it the way that you want it to. So you may just go and talk to them individually. At our institution, we have a platform called Capture, and it's linked to all the departments. So when I submit my documents, it goes to them, and they look at it and send me a bill, send me an invoice as to what I promised to pay for them to do the work. But at least everybody is on the same page, and everybody have to sign off before the study can open. We also have a clinical research trialist. We have somebody at the front end that sees the patient and collected toxicity, make sure the patient understands everything, and the outcomes that I'm collecting. And then we have somebody at the back end, which looks at the clinical trial records and pull it out and enter it into the clinical database. You might have one person doing all of this, but having two people is a good quality control to make sure everything is correct. Then we have the other thing is training your team. So it's not so much multiple classroom, but there's a study startup meeting that everybody listens to the same story, sign off that they have understood everything. So that training is important. If you're doing a multi-center trial, I strongly recommend, if at all possible, be part of a cooperative group or have a clinical research organization to be the core managing the relationship with other centers. It's not for the faint of heart. So I think I'll jump that one. I think we have talked about most of this. As the principal investigator, you basically promise you will look after everything. Everything is your responsibility. Usually a doctor or medical health professional who leads the team and ensures that your trial is regularly monitored, is responsible for preparation, conduct, administration of the grant, cooperative agreements, compliance with applicable laws and regulations. The last thing you want is to have somebody come and audit you and say you did something wrong and close down your study. We have a lot of internal monitoring to make sure everything is according to the rules and regulations and protect me as the principal investigator. And I'm sure it applies to you as well. So last question. Which of these items is not a requirement of the principal investigator? Monitor
you just
study.
said responsible for everything.
I have to have one answer, right?
Okay.
Monitor study participants' well-being to determine effectiveness and safety. Monitors the completeness of data capture. Responds to queries from the sponsor, patients, ethics review board. Ensures the study completes accrual within the projected period as estimated in the protocol. Reporting of serious adverse events as per protocol, applicable laws and regulations.
Right, so we have Oh, 65% answering. Okay, it's great. I'm sharing the results. So majority answered D, ensures the study completes accrual with projected period.
Yes, correct. All the others are the responsibility of a principal investigator. So my take-home message to you, successful randomized trials provide high level of evidence to inform the effectiveness of an intervention. It's all about minimizing bias. Superiority is the most common design, and successful implementation requires strong collaborative group, experienced principal investigator oversight, and a clinical research support group for data quality and monitoring. Thank you for your interest.
Yeah, thank you so much. It was really great overview of how to design and run the randomized trial. And it also shows how much work it is. And thank you for highlighting this. But it's really needed because if you can look at this paper comparing how many trials were run with different specialties, only 6% in radiation oncology and very little in LMICs compared to high-income countries, right? So there's a big disparity. So we really need to educate LMIC countries about running the trials. And thank you for doing this today for Ukraine. So we actually, in some of our projects, we do have randomized clinical trials. They are multi-center, so it's very ambitious and very brave of them to do this. So they are currently going through the process of designing these trials. So let's see how it goes. So we are very excited. Thank you so much. It was a really great lecture. I'll open the floor for discussion. Oh, I see one question in the chat. Thank you for the wonderful lecture. You've probably been through FDA audit. Is it really as scary as clinical monitors describe?
I am very well protected. So I have excellent teams that really cross the T's and dot the I's. But I think, yeah, if you should have somebody that is familiar with the clinical trials process that is appropriate to your environment, and make sure that you are in good hands.
I was wondering if you can comment. You mentioned that some of the trials had false results, and then you mentioned briefly about BMT for breast cancer patients. And we remember the story of Dr. Bazawoda, I think, from South Africa, right? Running the BMT trials that nobody else can actually confirm and have similar results. And he was showing fantastic results. And then at the end, it turned out to be false. He falsified data. Can you talk a little bit about this, the integrity of running trials and research?
Yeah, I think it's in many ways it's so easy for to falsify data. But that's why there's all the training required to make sure that we are held to the highest standards. I can't say much more than that. I think it's reliant on the investigators to be respectful of the data that you're putting out there. I think, especially for something like a randomized controlled trial, it's so difficult to reproduce it. So we want to make sure the best data is put forward, positive or negative. So I think the other thing to say is that the journals heavily emphasize, subscribe to the fact that even negative trials should be published. It might not be the New England Journal, but I think every lesson teaches us something. So make sure the data is good and share the lessons learned.
Yeah, that's a good point. In terms of your experience with designing the trials, what were the failure modes, you would say, that you would go back and do differently?
I shared one already. Make sure your primary endpoint is going to be feasible.
Yeah.
Early on in my career, I was invited to be the symptom control chair for the Canadian Clinical Trials Group. And that group is all about palliative care, supportive care. I actually have the director, just to show how difficult it is. I had a director of the program as my physician coordinator. And I always wondered, did they not trust me? Or they have to have the boss looking after me? And just to say that the first few trials that the group was running, they all failed. We had a methadone trial. It took like 2 years to, I didn't personally write it, but it was supporting, everybody had good intentions and they designed this trial and nobody was enrolled. And then there is another study that it was designed and it turns out that the drug it's a not unconventional medicine. So Health Canada would not approve it. So we couldn't put it in a study. And then there is another study that is very common that you are so slow in accruing that the study group will say you have to stop the study. This is not going to ever finish. So those lessons sort of distill to some of the things that I said. Make sure you have enough patience and you are collecting the things that you really need. And the primary endpoint is likely to be available. I have seen a lot of proposals from residents. They have these miles and miles of data collection form. I said, what are you going to do with all of these numbers after you collect them? Yes, you think about all of them, but what are you going to analyze? So make sure that the work is well spent. I think nothing beats working with people and share experiences to gain that experience. You don't see that published. The failed studies don't get published. Yeah.
That's right. But you can do some secondary analysis, right? But you have to also include the cost for statistician, right? To make sure that there is that cost to run the analysis with all that data collected.
Yes, that's right. Yeah.
And you can also do the amendments of the trial if you forgot or omitted something, right? So you can.
Yes. Yeah. So definitely amendments. So I said earlier that your protocol need to be published, accessible. But things change. The standard of care would change. So as long as you are aware of it, make the amendment, adjust your protocol, and justify it, it's okay to change.
And then Dr. Roach shared with us recently the story of his RTOG trial, right? It took him 18 years, like from the conception of an idea to now reporting at ASTRO meeting on this trial. And I think it's like one of the largest trials in radiation oncology. But the standard of care also probably changed, and we're treating much better now, right? So lots of things that changed throughout that time. 18 years, right? So it requires a lot of patience.
That's right. Yeah. But easy things don't it doesn't need all these all your new talents to do it. They are difficult. That's why they need you. So
yeah, that's right. Excellent. Thank you so much, Judith. Are there any questions from the audience? Any interesting topics you want to discuss? I was wondering, last question, if possible. You mentioned there's this big discrepancy between number of trials run, LMIC, HIC. I'm curious about, do we have some bias and skewed data? Because let's say we don't include enough different type of ethnicities and patient population, right? From LMICs in our trials. Can you comment on that?
I think definitely, like, even in my environment, Toronto is very multicultural. But even in this environment, most patients who participate are Caucasian. So, or I think that one need to have, I mean, it's easy to say, you have to have tools and translations that is accessible to patients, but it's far from being perfect. And of course, in low and middle income country, I can only infer the ability to run the trials will be even more difficult. But I think at the same token, it needs to be done, and hopefully with good collaboration, it can be done and answer the important questions, not to look for, I don't know, 1 or 2 months of progression-free survival like big pharma looking for, but asking those questions that really would change clinical practice in your setting.
Yeah, excellent. Thank you so much for such an amazing talk. It will be recorded and will be subtitled into Ukrainian, so everyone can watch it also later when they have time. So thank you so much for amazing lecture. We all learned a lot today. I'll see everyone in 1 month. Thank you.
Thank you
Dr.
so
Wong.
much.
You're
Bye-bye.
amazing. Bye-bye.